across the income spectrum. It seemed not to matter as much about income as it did about ethnicity. And so it's theorized that some of that is because the hospitals that are in minority communities might not be level 3 and level 4 hospitals. And so if you live within a minority community, regardless of what your economic status, you might want to go to the hospital that's in your community, and that's probably germane for Texas as well. If you live in a rural community, you might not want to travel to the big city to get your care, and so that's why it's so important that we institute the bundles can be scaled up or scaled down to what the resources of the particular hospital, but having some standard, some base standard, some approach that everyone is doing is I think what's really important about them.
Dr. Mott, did you want to add anything about the AIM program?
Yeah, well, I think that by establishing these AIM programs and establishing the protocols and the toolkits, then even our physicians throughout the communities, no matter what the level of hospital, they will be able to institute what needs to be done. They will see this particular patient, they have so many comorbidities, then they'll make a transfer. I suggest that you are going to need to see someone here at this hospital because I think delivery for your baby is going to need to be in a different place. So I think that by us coming together in the AIM project, actually setting the levels of care and educating physicians as to what the protocols are and when shifting should be done will help us to make a change so that all women, no matter their ethnicity, no matter where they come from, no matter where they live, will be encouraged to go to places that could truly help and be available for the risk that they have for hemorrhage or cardiac, all of the things that we talked about that could happen in that same day period, 7-day period, postpartum. And also, it will help us to develop programs that will go forward for that 365 days and dealing with postpartum depression, dealing with drug overdose and what needs to be done. So I think certainly, and Dr. Toy was going to talk about all the things that we're doing in the community to make that happen. And certainly it's legislative as well.
Sure. Can I just add something about the hospital aspect? So there are some paradoxes here because your highest maternal mortality are probably going to be your hospitals in the Texas Medical Center, not because they're unsafe, but because we've referred the sickest women to come to that location. So there's a little bit of paradox there. So for both the Pavilion, Texas Children's, and my hospital at Children's Memorial, we have patients come in by helicopter, by ambulance from all over the state that are the sickest of the sick, and we're trying to rescue, and sometimes those patients will die. So we may have higher numbers. That doesn't mean that one hospital is more safe than the other. The other paradox that you'll see is that for some health state hospitals or county hospitals that are affiliated with universities may be the safest place you can have your delivery, even though you're taking care of a very underserved population. And I would say that Ben Taub and then my other hospital, LBJ, probably are more advanced doing quality and safety. So as we tease out the numbers, we've got to keep that in mind. The great thing about AIM and collaborative projects like that is that it takes these fundamentals to every single hospital out there. Sometimes for patients, for hospitals that don't do a lot of deliveries, remember half of all deliveries in the United States occur in hospitals that deliver less than 1,000 babies a year. So a lot of these hospitals are in rural areas or they're in smaller communities. That would include hospitals up in Cypress. That would include hospitals in Richmond, in Oak Bend, in Pearland. These are smaller hospitals that we don't necessarily think as being rural, but they're definitely smaller with different resources and different exposures. So I think the AIM and those sorts of collaboratives are really a great way to take some of the basics to people that aren't necessarily seeing these sick women every single day.
Yes.
This is from the women's point of view. The Texas Tribune actually developed a little questionnaire. They suggested having women use it to advocate. And one of the questions was, like when you go to your provider, was, well, if I have postpartum depression, how would you, where would you refer me? What would you do? And I thought, well, this could be really a cool tool. I'm not sure how to use it, but I think getting women engaged and in asking those questions, or, most women probably don't think about developing a complication, but it was like, yeah, if I developed a complication, the hospital where you are going to have me deliver, are they ready to deal with the complication? Like I said, it would take some working on it because I think it was it's kind of medical, but I think we have to also look at that, the woman's self-advocacy and her empowerment to engage in these conversations with her provider.
Yeah, I always think that you get the medical care that you demand. One just thinks that the most is going to get her or his needs met best. Let's talk about mortality task force. Which of you is most comfortable discussing mortality task force? I don't know which of you that's more you. Although, by the way, you did a great job you were very modest in terms of saying you can talk about the hospitals and the nations.
Go ahead and build.
We can both. And I have some notes to refer to as well. So the Maternal Mortality Task Force, and this is it. I think this is the answer to the question that Dr. Mott raised in introducing the topic. What was different? What did California do different? Well, at the time when we were all down at a low rate, everything's great, right? But when the mortality rate started to rise, many large states, it happened, it's not unique to Texas, it's across the U.S. There was a rise in maternal mortality because, as has been mentioned, there's a rise in chronic illness as well as other issues. So what they did is they began to look at the deaths that were occurring in the state. As Dr. Blackwell mentioned, gathering data helps drive change. And so there were people in Texas who thought that we should do that too, and some of them are sitting at the table, but it takes a legislative will to have that happen. So it was not until 2013 that the legislature passed a bill that created the Maternal Morbidity and Mortality Task Force in the state. Okay, so that's 2013. They did not appropriate any money for that effort, but they placed it under DSHS, and through Title V block grants, DSHS supports economically the work that the task force does. Everyone on the task force is a volunteer. No one gets paid to do the work. What we do, and initially we had to establish ourselves. You had to create some guidelines. You had to create workflows, if you will. And so that took some years too. And I'm saying all this because in the media, there are reports that, nothing has been done or the task force is being slow. But you have to understand, it was on paper, create a task force. The commissioner appointed some people, and then we met, and it was like, okay, so how do we approach this problem? What do we do? And so it took some time to develop workflow and process. And so by 2014, we were actually reviewing cases. And so our role is to review every single maternal death and that has taken place in the state. And we don't just look at the what constitutes the maternal mortality rate, which is up to 42 days, but we're looking out to 365 days. And then to identify any trends and make recommendations based on those reviews. We do 6 things. We first identify what was the underlying cause of death. You might think that that would already be known, that it should be on the birth certificate, but sometimes what's on the birth certificate, the death certificate is not what caused the death. We look at whether or not the death was pregnancy related, whether or not it was preventable, and then what other factors contribute to the death. And then based on that, make recommendations. And I think Jim can probably speak to some of the contributing factors, because it's not just that a person was pregnant and then she died. We look at a great deal more than just the medical record and the death certificate.
I think one of the, well, not from our task force, but when you looked at preventability, when we were talking about preventability, where we need to work, I actually looked at a report from the, there was 9 task force that compiled the report. And one was the knowledge of warning signs, that the patient and family needed to know about the warning signs. So that's sort of like, how do we work that into what's medical and what we're looking at? Because often, we're seeing that may be one of the contributing factors is the awareness and the need to know to go for help and assistance.
So the other thing about reviewing the test, once you've reviewed and you've identified it, it was, number one, you're looking at 1 year's worth of data. The data that was on Dr. Mott's slides is aggregated data over a 4 to 5 year period of time. Because it's only when looking at larger numbers that you can actually identify trends. And so the state epidemiologist and the research team provides us an opportunity to aggregate the data and come up with recommendations based on that data. And so seeing that in the first 7 days, hypertension and hemorrhage were among the highest rate, or had the largest numbers in terms of cause for death. That's why a hemorrhage bundle and a hypertension bundle are going to be the first bundles that are being rolled out in hospitals statewide. And then the opioid crisis, when looking at the 365-day data, became apparent that overdose, suicide, homicide, behavioral health issues were the leading causes, and so that's why Texas became very actively involved in creation of the opioid bundle and supportive of the behavioral health bundle. And June mentioned early warning signs. All that means is recognizing signs of illness. If one of your family members says they're short of breath, if you notice that a pregnant friend of yours is looking particularly swollen, mentioning it, asking a question, asking the person after delivery how they're feeling, whether they're, how's their mood, taking ownership of recognizing that there are signs early on that hint at a problem, and encouraging people to seek help is critically important.
Another thing that now I'm trying to on right now. We also identified the fact that from the death certificates, often the information was not accurate, or when a death certificate is filled out, there's a particular box on there that they have to identify whether the woman was pregnant within 42 days, pregnant within the last year. So that whole gathering data and getting the really good information for us to make the best decisions we can about whether it was preventable or not. This is another separate area that is being worked on. There was a summit, and there's a whole group from with DHS that is actually working on this and working with the medical examiners and the justice of the peaces, and also the investigations when they go out to do these investigations of these deaths. If they're going, like if it didn't take place in a hospital, like they're often happening like in other areas. So then there's often a medical investigation of it, and looking at the information that's being available on those certificates to help us. That whole issue is being addressed as well.
I have a few more questions, but I do want to, before I finish my few questions, I want to open it up to the audience to see where you guys are right now and what things you're wondering about. So we'll start with the one right here.
My question is towards the behavioral health or the mental health. You're talking about the AIM bundle and program. Thank you. So currently, can you hear me? Currently, are you as practitioners, when you meet someone or when you see someone and you can see that there are causes that are happening, can you refer them to a mental health facilitator, to a mental health facility? If you feel like it is mental health related, behavioral health, Because statistically, when you have the high statistics of mental health disorder, and you were talking earlier about erasing and trying to get rid of that image and that idea that that's a problem, are you currently referring your patients to people that can help them in the behavioral health area?
I would answer first. I appreciate the question. I'm very, very fortunate that I practice at the Pavilion for Women, and we have Dr. Lucy Puryear, who has a large grant and is able to provide behavioral health services through a whole team within our system, so within the Texas Children's System. So we're very fortunate that we have that on. But speaking from the perspective of someone at a state level, there aren't services, and focus groups with physicians have found that many times physicians don't ask the question, healthcare providers don't ask the questions because they don't have anywhere to send the patient. So they may not ask the question because of the helplessness in that once you identify it, what do you do? And so encouraging our providers to ask the questions anyway, beginning to train OB-GYNs, family physicians. There's a move to having the state has actually authorized payment to pediatricians because, like has been mentioned, mothers they may not come to their postpartum visit, but they sure do take their child and they take their baby in. And so that's an innovative way of approaching the problem. But the task force absolutely identified that there were missed opportunities for screening for behavioral health services. And that was one of the recommendations from our second biennial report. We're required to report back to the legislature on an every 2-year basis. And one of the recommendations was that there needed to be resources and an increase in the behavioral health services in the state so that there was somewhere to send patients who were identified with need.
For Dr. Mott and Dr. Blackwell.
Right. This to me is where I think that we should be focusing a lot of our time and effort on what we can do better.
Yes.
I think that, childbirth is relatively safe if you deliver in a hospital in Texas. Certainly there's opportunities for improvement, but this is an area where we fail. We have resources in the Texas Medical Center because of the universities and the infrastructure, but out in the community and across Texas, an OB-GYN having access to refer her or his patient to a psychiatrist is lacking. Psychiatrists, for multiple reasons, don't want to or are unable to see our patients, and we don't have resources to provide that internally. I think the solution is going to be we're going to have to build into our education for our providers the ability to help screen and take care of these patients ourselves within women's health. That doesn't mean doing a soup to nuts care of women with behavioral issues, but the basics, except for when they become very, very severe, because I think it's unrealistic to think that we're going to have a great influx of access or new behavioral providers that are taking care of our patients. This is where I think that we need to focus a lot of time and effort to solve.
I would agree with that. I think that one of the things that we as practitioners have is we have an opportunity to truly bond with our patients. If we have that bond, then we will be able to assess things that are going on in their families. Certainly they'll feel more comfortable sharing those things with you. They may not give you everything, but certainly as a practitioner, you're going to be able to get an idea of things that are going on. Certainly we meet with them multiple times, and there are certainly things that we can interview them on that will help us to direct them in the right place. No, everybody in the community does not have psychiatric help available to them. But I think that developing a toolkit for overdose, a toolkit for postpartum depression, and things that our communities out in the booms can do to make a difference, to make sure that we're not having women in our communities succumb to suicide because of postpartum depression. So I think a lot of that lies on us. We haven't been as aggressive in dealing with these types of problems. We work well with what happens up to the 7th day, but we really have to have a continuity of care for our women for that entire 365 days. So it's going to take some long-term work on our part, as well as relationships that we develop with our women in order to make this change.
Another question on this side, and then we'll cover that.
Okay. In terms of preventability, does anyone have any comment on access to family planning prior to, pregnancy? I also want to just say I'm fascinated by the, disparity in the graphic that talked about 70% of these deaths are overdose related, and yet, the majority of those women are white women over 40, and yet, that's not what the chart looks like for Black women. So anyway, so family planning is really my question. Thank you.
Definitely a racial divide in terms of what it's causing.
Yeah.
Whether it's unhealthy to begin with for Black women and the drug issues for white women. But yes, you want to speak to.
I would say first, speaking to thank you for the question about family planning. We know that about 55 to 60% of pregnancies are unplanned, and that's based on surveys data that has been collected within our state. And so, and if your pregnancy isn't planned, you probably don't get early prenatal care, not having early prenatal care is related to a higher incidence of maternal morbidity and mortality. And so planning, being able to decide when you want to have a baby and when you don't want to have a baby is incredibly important. Access to safe, long-acting contraceptives is extremely important. I was on a panel a couple of weeks ago with someone who represented Planned Parenthood here, and so the decrease in funding to clinics that are able to provide reproductive services has certainly impacted women's access to reproductive techniques, so contraception, birth control, however you want to describe it. And that certainly contributes to a rise, I think, in maternal morbidity and mortality, because if you can't control when you get pregnant, if you can't have the proper spacing, because we know that having pregnancies too close together, less than 2 years apart, increases the risk as well. And so that piece is extremely important. And thank you for making your other comment. We never want our data to confuse the picture. There is not a higher incidence of suicide in the African American population that was looked at least by the data that we have looked at in our state. The causes, when divided by ethnicity, hypertension and hemorrhage were the two that were higher in African American women, and the suicide rate was higher in women who were over 40 and white women, actually. And so there are differences according to race and ethnicity, the causes of death.
Do we know much about the Hispanic community? Because especially in Houston, there's a huge Hispanic population.
I think the thing that's interesting about the Hispanic community is what's called the Hispanic paradox, in that if you looked at that, I think it was the second slide, Hispanic women have the lowest rate of maternal death in our state, and they account for the highest number of births. So we have to learn from them, and we have to say it. There's some people who feel that it's because they approach pregnancy as a community. And many providers will attest to the fact that their Hispanic patients often come with their mom or their sisters or their brothers or their uncles or their dads, or they approach it as a community. So there is perhaps something there, but then there's also, and it's going to take some years to see whether this bears out. If there's a difference, once you've been in the US for generations, will we continue to see them have the lowest rate? Or will they become more like white women or even more like Black women? Because there is the economic difference is still there. There's a large number of the Hispanic population that is receiving state funds for deliveries, and I don't want to single them out because almost 60%, 55 to 60% of deliveries in this state are funded by state funds. So it's no one ethnicity that is makes up all of the women who are needing access and using state funds, public funds for care. But it's a paradox why the Hispanics have a much lower maternal mortality rate.
I know someone over there has a question, but she has the mic in the front row, so let me.
I'm just going to comment on family planning. The Texas Collaborative on Healthy Mothers and Babies, we have a community work group. And one of the initiatives we want to work on is getting providers to ask that one key question: do you want to be pregnant in the next year? So if we could have that happening, then we can have that conversation with women about what you want to do and what are the options available and what's available for you. And then also with the Healthy Texas Women, for women who are qualified for Medicaid, once they have had their 60 days, they won't be automatically enrolled into the Healthy Texas Women. And so they will have access to family planning, some screenings, some treatment for hypertension, diabetes. I think it's screening for postpartum depression. For mothers who have CHIP perinate, they have to apply for family planning. So that is an issue, and it is we're looking at some of the issues around that. So yes.
My name is Jackie Griggs. I'm a certified nurse midwife and a community-based midwife. I work at a birth center here in Pasadena, Bay Area Birth Center. And one thing that countries that have the best or lowest maternal mortality rates, states that have the lowest, are states that utilize midwives. And I haven't heard anything today about how important midwifery care is for women. I really want to see more support for midwifery care. Often when we have a problem at the birth center or with a home birth and we try to transfer in, we're met with contention, and it's very unpleasant sometimes. One hospital that has been really wonderful to take our transfers has been Top. We really appreciate the care that we've been able to receive for our clients there. We just want to say that we know that midwifery care is an important part of the answer for this maternal mortality problem. We rarely have women with these complex problems because we try to refer them early on, but we want to work as a team. We want collaboration. It's very difficult. It's difficult for us to find doctors to work with. And so representing the midwives of Houston, we have a strong midwifery association here, and we're easy to find. If you want to work with us, we want to work with you.
Thank you. Gentleman back here, and then we'll come back there. I know you don't have the mic. They're getting the mic to you, so stand by. Sit by.
Thank you. Thank you. My name is Munir. As a first-year medical student, I'm fascinated with this such an informative discussion. My question goes to the panel in general, anyone that wants to take it, and it's in regards to the opioid crisis. So this morning, Francis Collins, the director of the NIH, launched the HEAL initiative, granting $1.1 billion to fight the health crisis. And so my question is, what challenges do you foresee that might prevent pregnant women from being included in and benefiting from these efforts?
We didn't ask an easy question, so you get the question of the day. I think the biggest challenge, as I see it, is that drug use in general and opiates as well are more of a symptom than the problem itself. As somebody that has people in recovery in my family, the drugs are often the treatment for something that's underlying. The number of our patients that have dual diagnoses, the number of our patients that suffer strife or challenges or violence or poverty is very high, and drugs is one part of the solution, not a good solution by any stretch of the imagination. So assigning money to the opiate crisis is great. How that money would then get allocated to deal with the mental health issues that we've been talking about, access to psychiatric services, resources for these patients that have these problems at a societal level. If we dig down into that, it's not just about having new experimental medications to take care of people as opposed to abstinence. It's much more complicated than that. And if resources get allocated towards that, I think we'll make a lot of progress.
You have some battle want to comment with that? Okay. Outside of your purview.
Well, I was just going to say, we just had a presentation on treating women who were heroin addicts, and listening to the lecture, seeing the amount of work that it would take to train physicians. You asked what are some of the barriers for pregnant women. I think not having enough people trained in the treatment is number one, and then the societal stigma that's attached. One of the issues in terms of identifying, it's still a crime, and so if you identify a drug screen is positive, when a baby screens positive, unfortunately the approach is often not let's help the woman, let's treat the woman. It's let's call CPS, let's remove the children from the home, let's do things that unfortunately are, hearing in my ear, destructive to the family. And so to me, that's one of the big barriers in treating, because women know this, and so they won't seek care. And so not only are they not having their addiction or other comorbidity, the other behavioral health issues, they're not having those things treated. They may not get treated for just their pregnancy because of fear of criminalization of what is likely a behavioral health issue.
Thank you very much. My name is Liz Holland, and I'm an RN, and I work at Santa Maria Hospital, which is probably the premier substance use treatment facility for women, pregnant women, and their children in the state. And so I'm very proud of what we do, because we have answers for you if you will refer clients to us. We certainly are seeing great success. I'll make one comment about overdoses. Many of the overdoses are accidental. Someone, I think, in the panel, I don't remember who commented that, perhaps someone who's tried to stay off substances during pregnancy, they deliver and then they restart afterwards because they haven't had the treatment necessary. They go back on the same dose that they were on before they stopped, and that's enough to cause them to have an overdose and die. So it's not necessarily that they are trying to commit suicide, they're trying to get help for whatever the issue is that they have. But I'd like to make a comment before, a request to you guys, especially most of you are OBs, and hi June, nice to see you again. There is a treatment for opioid use disorder, and it's medication. And it's methadone, and it's buprenorphine, and there's tremendous stigma to mothers receiving it. I personally try and get prenatal care for my moms that come into Santa Maria, and I have had OBs say, on methadone, can't help you, sorry. And so I've had to go to other sources to find it. So those are issues that, as you guys are moving in your community, your medical community, and a medical student here, start to pick up on that, because it's just like diabetes. It's a treatment for this disease, and it needs to be recognized as how effective it is. So I just make that request to you. Thank you so much.
I'd like to thank you for making that comment, and certainly I think that many of the physicians, especially in our medical center, are aware of the need for the transition to methadone. And certainly we are treating ladies, and they are accepted in the practices during their time. And certainly the conversations that we have about what's going to happen after we have this baby, where are you going to go, what is the treatment plan for that, that gives us all the time we need to make a transition and to get them to understand and believe that they don't have to go back to the same things.
Yes, ma'am. Go to the microphone.
There.
Hi, June, I've heard you say several things about continuity of care and also about the empowering women to be speaking up on their own behalves. And as a doula for the last 5.5 years, I see that we might be part of filling that role, and I'd like your input. Dr. Ortique, I've had the opportunity to work with you at Texas Children's. What do you all see as the role of doulas and, as Jackie said, of midwives in supporting women in maternal care?
Well, I think that if that's the woman's choice and she would like to have someone there, I think that's excellent, because that's an advocate for her who may speak up when she may be getting into a place of lacking the power to do so. I know I've been taught we have midwives, and I have midwife colleagues, and I've worked with some of the students before, but some of the areas where you potentially could get engaged and involved in is, like, we do have our impact collaborative. That would be an area where you could engage with. And then just another comment I wanted to make is that the Houston Endowment actually funded research to look at what was happening in Harris County related to maternal mortality and morbidity. And they have made their recommendations to the steering committee at the end of March. And now going forward, they have a number of different groups that are going to be working on a lot of different things, and one is wraparound services and medical services combined. So one is advocacy, some is awareness, and one is implicit bias. So I think if there's people who want to get engaged and involved, right now we decided you could just get a hold of me, and then I will send your information out to the appropriate people. So these are some ways that people can get involved.
Dr. Blackwell, as we wrap up, do you give us 30 seconds on what you might invite the audience to do if they want to do something toward working for a solution? Be helpful.
Sure. I'll just wrap up with the concept of the role of doulas. If any of you have had to go to a hospital or have to take your parents to the doctor or had surgery or have had anything to navigate with healthcare, you see how hard it is. It's impossible sometimes and incredibly frustrating. Doulas as patient advocates and navigators would be a terrific role, just in general health related to pregnancy. So I would very much think that would be a wonderful role.
Dr. Ortique, your last 30 seconds.
So quickly with regards to doulas, ACOG has supported that doula care does help decrease morbidity and mortality, and I would encourage that you advocate for doula care to be able to be covered by Medicaid, because again, 55 to 60% of deliveries, Medicaid women, you have to pay for doula care, and so we have to advocate for increased access to care. And so that would be my plea, is that we advocate for expansion of access. That means expansion of Medicaid, extending it out to at least 12 months after delivery, to allow women to have care during that vulnerable time, and access. My final thing is that healthcare should be a right. It should be a right. You have the right to bear arms, you have the right to free speech, but you do not have the right to healthcare in this country. And until it is a right, until it's codified in the Constitution as an amendment, we'll continue to have these issues.
Well, my point is that we're a community. Certainly, we're working in the towers, the that you guys are working out there as the footprint people, but we've got to communicate together. We've got to have more of these talks. We've got to have more of these discussions. We've got to share the patients that we're dealing with so that we can truly get them to believe that they don't really have to have this and what the factors are to make the change. So thank you for being here.
Thank you, everyone. My name is Linda Rhodes, and on behalf of the Women's Fund for Health Education and Resiliency, thank you for being here today. I want to thank our panels, Dr. Blackwell, June Hankey, Dr. Carla F, and Dr. Wanda Mott, and thank you, Dr. Mott, for bringing this important topic to our attention. And I want to thank the partnering agencies. We couldn't have done this without the March of Dimes, the McGovern Medical School at the University of Texas Health Science Center, that's a mouthful. Harris Health Systems, Women's Specialist of Texas at Texas Children's Hospital, as well as our lovely moderator, Gina Gaston. And most importantly, we couldn't have done this series if it wasn't for our good friends here at the McGovern Health Museum, Dr. Melanie Johnson, LaTanya Miles, and their entire team who made today possible. I want to just let you know, if you have further questions or if you want contact information or access to some of this information, you can email me at linda@thewomensfund.org and I will, connect you with the right person. But I did want to mention our next free lecture series is our Women's Health Lecture Series at the University of Houston downtown. And I think we touched a little bit on it today, but you may be interested. It's going to be violence against women. And we're bringing in ADVA, the Aid for Victims of Domestic Violence or Abuse. So you may want to see that. It's going to be on Tuesday, April 24th from 1 to 2:30. It will be streaming live through the University of Houston. We will have it on our website, but it is free and open to the public. We are working on our next 2 doc talks. They will be later in the year, August and in November, and we have some topics we're throwing around right now at the Health Museum. And we do not have dates on those. But if you have topics that you're interested in, please email those to me, because we want our doc talks to be innovative, cutting edge, and things that our public needs to know about today. So we can all join this fight. As a mother of 2 boys and 2 stepdaughters and grandchildren, I want to know that my babies are going to be safe when they give birth. So, and lastly, thank you, Health Museum, for giving us this wonderful space to do it. And hopefully you'll make plans to be with us at the next doc talk. Another round of applause for our students.